Hey, welcome back. It's Dr. Suchard here with another clinical toxicology video, and this time it's about local anesthetic toxicity. The learning objectives are that once you've watched this video and studied the related course materials, you should be able to describe the mechanism of action of local anesthetics and use that to predict which organs will be affected with severe toxicity, and to be able to name at least 2 non-overdose related adverse reactions that can occur with local anesthetics. Local anesthetic drugs produce anesthesia, the absence of sensation, by blocking sodium channels in nerve tissue. In the upper right here we see that local anesthetic drugs diffuse into the cells and bind to sodium channels. And below we see a graph of a neuronal action potential. The initial rapid depolarization is due to sodium influx, but if the sodium channels are blocked, there will be a failure to initiate and to propagate action potentials. If the nerve that's blocked is a sensory nerve, that sensation is blocked and you get anesthesia in the area receiving input through that nerve. There are several kinds of adverse effects that can occur when local anesthetics are used, but not all of them are simply due to excessive dosage. The effects I'm going to be mentioning again after this slide are highlighted in blue. You can indeed get local anesthetic toxicity from getting too much drug or getting it too fast, and this can result in seizures or cardiac dysrhythmia. Some people may react to catecholamines like epinephrine, which are added to some local anesthetic solutions to delay and reduce systemic absorption and control local bleeding. Some people can have vasovagal events, and maybe some of these people might have had that occur anytime they're around needles. Some people have local anesthetic allergies, and if too much local anesthetic is given for regional anesthesia involving the spine, or if it's instilled in the wrong space, unintended degrees of spinal blockade can occur. And finally, several local anesthetics might induce methemoglobinemia, although benzocaine is the one most frequently associated with this toxic but non-overdose related effect. Getting back to allergies for just a second, local anesthetics come in 2 chemically distinct categories, either esters or amides, and the majority of people who have such allergies are allergic to the esters. On the left we see a list of the local anesthetic esters, and the amides are on the right. If a patient is allergic to one ester, they're likely to be allergic to the other esters too, since they share a common metabolite, PABA, or para-aminobenzoic acid, that's the probable allergen. In such a case, then, you should be safe in choosing a local anesthetic from the other structural class. And a few other brief notes. Novocaine is the trade name for Procaine, and you're much more likely to hear Novocaine used by a patient than the generic name. If you're trying to figure out if a given local anesthetic is an amide or an ester, you can look at its generic drug name. If it has 2 letter I's in it, one in cane, and another letter I in the part of the name before that, then it's an amide. As mentioned, methemoglobinemia can occur from exposure to several local anesthetics, but this is by far most commonly seen with exposure to benzocaine. I'd hazard to say that benzocaine is the leading cause of methemoglobinemia seen in healthcare facilities. Benzocaine has properties making it useful topically on mucous membranes, so it doesn't even need to be injected. Brand name Hurricane is 20% benzocaine that is often used as a spray, say to numb the mouth and throat for airway procedures or endoscopies. And it also comes as a gel in multiple flavors, where it might be used for ENT or dental procedures. Benzocaine is also available over the counter in multiple products to help numb the mouth and throat and for dental pain. And it also used to be found until very recently in over-the-counter preparations for infants to treat teething pain, but the FDA put pressure on the manufacturers and those drugs marketed specifically for teething were discontinued. You can find a discussion about methemoglobinemia and how to treat it in a separate video. Here's a quote from the Goldfrank chapter. Considering the frequency of local anesthetic use, clinically significant toxic reactions are relatively uncommon, amounting to less than 0.5% of reported fatal poisoning cases. Iatrogenic poisonings result from inadvertent injection of a therapeutic dose into a blood vessel, or from repeated use of a therapeutic dose or unintentional administration of a toxic dose. Because they are sodium channel blockers, toxicity from local anesthetics preferentially affects well-perfused tissues with electrically excitable membranes, since they are dependent on those sodium channels working to function properly. This means that we'd expect effects of serious toxicity to occur in the central nervous system and the heart. On this slide, we see there's a spectrum of toxicity depending upon the local anesthetic concentration. Toward the lower end of the toxic range, we see milder neurotoxic effects like numbness and lightheadedness, which can progress to loss of consciousness or seizures, and only at the highest ranges will it cause significant cardiotoxicity. And now for more chapter quotes with regard to what's seen with local anesthetic cardiotoxicity. The sodium channel blockade slows impulse conduction, resulting first in EKG changes with prolonged intervals, and progressing to hypotension and eventually cardiac arrest with asystole. Fortunately, we should be able to observe CNS toxicity at levels well below those causing severe cardiotoxic effects. If the patient gets a large bolus dose, they could proceed directly to severe cardiotoxicity, but we wouldn't expect cardiac conduction defects in anyone who wasn't also showing neurotoxic effects. Treatment of local anesthetic toxicity will depend on how severe it is. As with most poisonings, the treatment is primarily symptomatic and supportive, although with very sick patients that level of support could be quite intense. For minor neurotoxicity, like a patient feeling weird or dizzy, but they're awake to tell you about it, they probably don't need anything specific. They can be monitored and observed, and the symptoms should resolve as the drug is metabolized away. If they occur, seizures would be treated pretty much like any other cause of seizures, with attention paid to the patient's airway and ventilation, since acidosis from hypoventilation could make things worse. If cardiotoxic effects are seen, they should initially be addressed by standard, advanced cardiac life support measures. But in the most serious cases, standard ACLS is not likely to help, especially since ACLS doesn't have much to offer a patient in asystole other than continuing CPR. But there is a relatively recent development to treat such patients with lipid emulsion therapy, and this is going to be covered in a separate antidote-specific video. Don't miss it. In fact, if you're interested, you should probably go watch that video about lipid emulsion therapy right now. You go do that. I'll be seeing you around.